All right, let's talk about something that can feel a little intimidating but is so important: managing an intercostal chest tube. We're not just talking about a piece of equipment here, we're talking about a patient's lifeline. And getting this right, well, it's absolutely non negotiable. So picture this: you're at the bedside, your patient is relying on this device. How do you know, I mean, really know, that every single thing you do is the right move, that it's safe, effective, and actually helping them heal? The stakes are just, well, they're sky high. And that kind of confidence, it only comes from being crystal clear on what you're doing. So here's our game plan for this explainer. We're going to cover everything from start to finish. We'll start with setting the stage, go through that crucial pre-procedure checklist, and then we'll break down the drainage system so it's not so mysterious. After that, it's all about monitoring and care, patient recovery, and we'll wrap up with the big safety takeaways you just can't forget. Ready? Let's get into it. Okay, first things first, setting the stage. You know, success here doesn't start when the procedure begins. Nope, it starts way before that, with rock-solid preparation. This is the foundation for everything else. And that leads us right to the pre-procedure checklist. And look, this is way more than just paperwork. Think of it as your safety net, a step-by-step plan to catch any little mistake before it becomes a big problem. So let's break down these 4 things you absolutely have to do. 1, verify the practitioner's order. Is this the right thing to do right now? 2, you dig into the patient's record. You're looking for allergies, labs, imaging, the whole picture. 3, confirm that patient's identity. No shortcuts. And 4, make sure that informed consent is signed and sealed. Seriously, these aren't just boxes on a form. Each one is a layer of protection. Now, let's talk about positioning because it's so important for getting the best access. For an adult, you're typically looking at them lying flat or maybe slightly elevated, with the arm on that side up and over their head. That really opens up the space between the ribs. But for our tiniest patients, the neonates, it's a bit different. The focus there is all about keeping their airways safe, so we elevate their head just a little bit. Okay, so during the insertion itself, your whole world shrinks to that immediate area. What does that look like? It means getting ahead of the pain, managing it before it even starts. It means doing that all-important timeout. You know, that moment where everyone, and I mean everyone, stops to confirm right patient, right procedure, right site. It's so simple, but it saves lives. And all this is happening while you're maintaining a perfectly sterile field and watching those vitals like a hawk. All right, time to tackle the hardware. Yeah, the drainage system can look pretty complex at first glance. I get it. But trust me, once you break it down, it all makes perfect sense. And here's a look at them. These are pretty much the 2 main systems you're going to see out there: the atrium ocean, which is wet suction, and the oasis, which is dry. Yeah, they look a little different, but don't let that throw you. The way they work, the basic idea behind them is exactly the same. Setting one of these up is a really precise dance. There are 4 main steps. First, you get all your gear ready on your sterile field. Then you get the tubing ready, making sure there are no weird dips or loops where fluid can get stuck. Then, and this is super important, you fill that water-sealed chamber right to the 2-centimeter line. Not more, not less. And finally, you dial in the suction to whatever level was ordered. Every single step matters. So let's zoom in on that water-sealed chamber, because it's the real star of the show. What's its job? Well, think of it like a one-way door. It's genius in its simplicity. It lets all that trapped air and fluid escape from the chest, but that little bit of water, that 2 centimeters, stops any air from getting back in. That's the magic right there. That's what keeps the lung from collapsing. Okay, so the tube is in, the system is connected. Now what? Now your role shifts to being a detective. You're on watch. And this isn't just about glancing over now and then. It's about active, vigilant monitoring. You're constantly asking, what is the system telling me right now? And this shows you the 2 big things you're looking for in that water seal chamber. Over on the left, you've got tidling. See that? It's just the water level gently rising and falling with the patient's breath. Totally normal. Now, if it stops tidling, that could be good news, like the lung is re-expanded. Or it could mean there's a kink in the line. Something to investigate. But then look at the right. Continuous bubbling. That's not normal. That's a sign that there's an air leak somewhere, either in the patient or in the tubing itself. That's your cue to start troubleshooting. Now, suction is definitely not a one-size-fits-all situation. You have to tailor it to your patient. For most adults, you're looking at around 20 centimeters of water. But for kids, you dial it back a bit. And for neonates with their super fragile lungs, you bring it way down to just 5 to 10 centimeters. Getting this right is absolutely critical.
When it comes to the drainage, just remember these 3 words: monitor, mark, report. It's a simple loop. You're constantly monitoring the color, the consistency, and how much is coming out. You're marking the level on the chamber every so often so you can track the output. And you're ready to report any sudden changes. I'm talking a sudden gush of bright red fluid, or if the drainage just stops cold. That's an immediate.
And please, remember this. You're treating a human being, not just a chest tube. So your assessment has to be about the whole person. You're checking vitals, you're listening to their lungs, you're looking at the dressing, and you're feeling the skin around the insertion site for crepitus. That's that crackly, Rice Krispie feeling under the skin that means air is leaking where it shouldn't be. And you have to empower your patient. Tell them, if you feel any new pain or have any trouble breathing, you tell me right away. All this careful monitoring naturally leads us to the next big thing: recovery and mobility. This is where we shift from just watching to actively helping the healing process along. Because a patient with a chest tube should not just be lying in bed. You've probably heard it before, but mobility really is medicine. Getting your patient up and walking, even for short distances, encouraging them to change positions in bed, teaching them how to cough and take deep breaths. These aren't just nice-to-haves. They are absolutely essential. This is what helps that lung re-expand and prevents nasty complications. Okay, we're heading into the home stretch, and this is maybe the most important part. These are the critical safety rules, the things you have to burn into your brain and take with you on every single shift. Listen, I really want you to focus on this one, because if you remember nothing else, remember this. Do not clamp the chest tube, especially when you're moving a patient. Why? Because if there's still an air leak, clamping that tube traps all that air inside the chest. The pressure builds, and it can cause a tension pneumothorax, which is a life-threatening emergency. So unless you have a direct order for a very specific, very brief reason, the clamps stay off. You always have to be ready for what-ifs. That means keeping emergency supplies right there at the bedside. So what if the tube accidentally comes out? Your first move is to grab a sterile dressing and tape it down on 3 sides. Just 3. That lets air out, but not back in. What if the whole drainage system cracks or breaks? You swap it out for a new one, fast. You never just leave the tube open to the air. So let's wrap this all up. Let's boil it down to 4 key principles for excellent chest tube care. Number 1, always maintain the integrity of that closed system. Number 2, monitor your patient continuously, the whole patient, not just the machine. Number 3, get them moving. Encourage that mobility and those breathing exercises. And number 4, our golden rule: don't clamp the tube, and always, always be ready for an emergency. So I'm going to leave you with a question to take on your next shift. After everything we've just talked about, when you walk into that room, what's the very first thing you're going to check on your patient with a chest tube? Really think about that. Let that question shape how you approach their care from now on.